Hello, everyone. We'd like to welcome you to our ePulse webinar on pediatric glaucoma surgery, featuring some of the world's most renowned experts in pediatric glaucoma. I'm honored to be co-moderating this webinar with my dear friend, Dr. Mohammed Said, who has generously helped in creating this event. Mohammed is a glaucoma specialist and pediatric ophthalmologist practicing in Miami, Florida. He also worked as an assistant professor of ophthalmology in Boston Palmer Eye Institute. So without further ado, Mohammed, do you want to start?
Thank you so much, Dr. Yasmin, for the kind introduction. I'm very happy to be here among this amazing group of world-renowned pediatric glaucoma specialists. We're gonna all be learning so much today. And so the meeting, we have several speakers today who are gonna all update us on their technique and their strategies on pediatric glaucoma. We're also going to be asking them questions after each of them finishes their presentation. And the audience can, of course, participate by asking questions, but please, may I ask the audience to pose their questions to the Q&A section rather than the chat. Yeah, we are looking forward to an amazing meeting today. So today we actually we're gonna start with Dr. Elena Betrian, who's gonna update us on the choice of surgery, and then Dr. Hala Hilali, she's gonna talk about Cahogue dual blade trabeculotomy or trabeculectomy, and then Dr. Yasmin Sayed, she's gonna talk about the ab external trabeculotomy. Dr. Zainab Akhtas, she's going to talk about GAT, and Dr. Alana Grajewski, who's going to be talking about glaucoma drainage devices, and Dr. Albert Khouri, who's going to update us on lasers in pediatric glaucoma. And Dr. Yasmin, I think we're going to actually start with Dr. Elena Betrian. So Dr. Elena Betrian joined the faculty at Bascom Palmer Eye Institute as an associate professor of ophthalmology a few months ago, coming from from Mayo Clinic, where she actually was the chief of pediatric glaucoma. She's extensively trained. She actually finished training in Spain, and then in the US, she did a glaucoma fellowship in UCLA, Sinai Institute, and then she trained with Dr. Alana Grajewski in the University of Minnesota in pediatric glaucoma. And she's currently the Director of Education at the Balkan Center for Glaucoma, for pediatric glaucoma. And she's also Director of Research in the Childhood Glaucoma Research Network. Dr. Betrian, please go ahead and unmute yourself and share your screen, and yeah.
Thank you, Dr. Sayed. So I'm gonna speak today, as we said, about the choice of surgery. So we're gonna go over all the surgeries today and the preliminary introduction. This is an introduction of what we do and when we do it. I don't have any financial disclosures. And we do know that adult glaucoma is not like a pediatric glaucoma. It's not the same kind of glaucoma on a smaller eye, because pediatric glaucoma is a panocular disease, and it affects the anterior and posterior segment in different ways than in adults. For the same reason, the treatment of childhood glaucoma is not going to be the same as an adult patient. We know the medications have a more limited role, so we are more based on surgery. And we have basically three main groups of surgery. We have angle procedures, we have filtering procedures, and cyclodestruction. We will be talking about the ab interno and when do we do those ab interno procedures like goniotomy or goniotomy-like procedures, ab externo procedures like trabeculotomy or trabeculotomy-like, and some filtering procedures. And on this category, we do have three groups. We have trabeculectomy, deep sclerectomy, and glaucoma drainage devices. And lastly, our third group of surgery is the cyclodestructive procedures. I'm going to be talking about when I like doing those procedures, and the rest of the speakers would go in depth in the techniques. So we know, just to mention again, medications have a limited role. They are used as temporizing agents before surgery or adjuvant therapy after a partially successful surgery. Often they are insufficient to control pressures in a lot of types of childhood glaucoma. And they are not as well tolerated as in adults, and they have other adverse effects that they don't have in adults. So that's why we talk about surgery on pediatric patients. Angle surgery is often the procedure of choice. It has a success rate in primary congenital glaucoma of 85, even a little higher depending on the series. But we know that these procedures have less success in other types of secondary childhood glaucoma. When we speak about angle surgery, we can talk about ab interno versus ab externo procedures. For ab interno procedures, it's key to have a good visualization. I need to have a gonio lens, we need to position the microscope and know very well the anatomy of the angle. If we don't have these three things, we are not gonna have a successful surgery. So then we would not be choosing this procedure. We also need to be aware that we need to minimize bleeding during the surgery to also allow a proper visualization. So it's very important during our exam under anesthesia to evaluate all these things, evaluate the view of the angle prior to the procedure, and have a good view before draping the eye sterile, not applying pressure on the cornea, and having a good view of the angle. If our view is good, we can proceed with a angle surgery. I do like ab interno procedures a lot, but it's very important to get a good view. We did this setting of the microscope before. I do like to look at the angle with a microscope before the exam, and then I do the same afterwards. So we are tilting here the microscope, lifting the oculars to have a good view. The microscope is tilted 40 degrees, and then we tilt the head of the patient 30 degrees away. And we make sure we have a good visualization. We apply viscoelastic in the cornea and our gonio lens of choice before we do proceed. So angle surgery we can do ab interno or ab externo. For ab interno, we said basically to have a clear cornea. Ab externo procedures, we can do them with an opaque, either clear or opaque cornea. I do like, and I tend to do ab interno procedures if I have a good view, because that leaves the conjunctiva intact. Those patients sometimes will require a succession of surgeries during their lifetime, and it is important to have a spare conjunctiva in case we need future surgeries like glaucoma devices or trabeculectomies. Also, ab interno procedures are a faster procedure. But ab externo procedure is a good technique to have in our toolbox as a pediatric surgeon. We do need an incision in the conjunctiva, and a lot of times we're gonna choose to do these incisions temporally because that will not interfere as much with trabeculectomies or glaucoma drainage devices that might be needed in the future. Ab externo techniques are more time consuming as well, and also have a steep learning curve. But it's important to use ab externo techniques because it can be very helpful when we have shallow chambers or in cases of anterior segment dysgenesis. Can you guys hear me? Sorry. Huh.
Yeah, so you can actually...
Oh, sorry, I'm sorry. And I took it off. Oh, sorry, I thought I was disconnected. Sorry about that. So when we do angle surgery, the sequence of surgeries is do angle surgery. We can go ab interno, and this is an example of a goniotomy. Here we see an angle lens with a needle, and that can allow us to open the drainage 4 to 5 clock hours. And here we have a picture of ab externo procedure. This is a trabeculotomy, harsh trabeculotomy, when the cornea view is not as clear and doesn't allow good visualization. We also have other options to treat the angle almost 360 degrees. We can do a temporal goniotomy with a needle, or we can also do a nasal goniotomy. Like we can even do both combined. Then also we can use instruments like the TRAP 360 Omni, which we have here in the screen. This is an instrument right now. We have the newer version, which is the Omni device, and that allows us to do canalization of the Schlemm's canal and unroofing of 360 degrees of the Schlemm's canal. And another procedure that allows us to do treatment of the internal of the angle 360 degrees is the gut, which we're going to hear in detail in a few minutes. I do like treating the 360 degrees of the angle initially if that is available to me. And I like a lot Omni and also gut, even as a primary procedure. As ab externo procedure, we can do nasal and temporal harms if we wanted to. And that way we can literally treat pretty much 360 degrees. But this is really time consuming. That's 2 conjunctival flaps and 2 scleral flaps. And there are other ways to do a circumferential trabeculotomy. Is a suture using a Prolin suture and using the eye track illuminated catheter. And here we have just a screenshot of how we found the Schlemm's canal, and we can see some fluid coming out of our incision. This is the harms that we had before. So instead of using a harms, we could use thread photoprolin suture circumferentially, retrieve it as our ostomy and treat it, or we can use the iScience catheter as well. When angle surgery fails, a lot of times we can repeat angle surgery, or a lot of times we will step into other procedures like filtering procedures. And in this group, we have a trabeculectomy and deep sclerectomy. Those are good procedures for, in my hands, I like those procedures for older patients for juvenile open angle glaucoma. Because children, the younger a child is, they have a higher increased risk of a scarring, and that can predispose to a failure of the surgery. Also, we are not sure about the full effects of the use of antimetabolites in children. And as well, the risk of endophthalmitis that it can be seen with some trabeculectomies and not as much with deep sclerectomies. Deep sclerectomy and trabeculectomy are titrable procedures, so that's very interesting because we could do things to adjust to the level of pressure we want for the patient, but we do need a level of cooperation of the patient. So in very small children, we don't have that, and that's why I tend not to use that on small kids. What I like using is glaucoma drainage devices a lot. If my angle surgery is done and it's not working, then I would go for a glaucoma drainage device. We have mainly 2 types, valve and non-valve. We use basically Ahmeds and barbels. I do prefer to favor a little more barbell implants. I do think medium long-term gets a little better lowering of pressure. But in a lot of occasions that we do need a very fast lowering pressure levels, Ahmed shunts are also a very good option. I prefer to place them superior-temporally, but every case we have to individualize because there's a scarring and thinning that need to be accounted for. It's important in children to have a different technique, which we will see in a little bit later, and also adjust our technique to the different types of glaucoma that we have. And finally, cyclodystrophic laser. We do have available the transscleral and the endoscopic lasers. With the transscleral, we have the G probe, and also we had more recently an MP3 probe that has been redesigned and has been available since end of last year. I would say that in my hands, I do use them. I do use cyclodestructive procedures, but with caution. There has been described cases of sympathetic ophthalmia with the use of this laser. I do like the MP3 probe. In my hands, I had good results. It's more gentle. Sometimes we need to repeat it. And that is a procedure that I would reserve as like a later last resource in children, because children tend to have more inflammation, which is harder to evaluate in clinic as well. So as we said, we need to individualize. This is the childhood glaucoma classification. And we know that most of our pediatric patients with glaucoma, they're going to be primary congenital or also cataract patients. Primary congenital glaucoma has very good success with angle surgery. And then we have a group of secondary glaucomas that they don't have as much success with secondary and with angle surgery, but I still like treating it and giving it a shot. If the glaucoma is not very, very advanced and severe, if the pressures are not extremely high, I do like to treat with angle surgery. Sometimes the success rate is only 50%, but in some patients we can gain some time and years. So to summarize, the procedure of choice, we need to remember, medications are used as temporizing or coadjuvant agents. Angle surgery is the procedure of choice. For our internal procedures, we will require a clear cornea. And we'll try to treat 360 degrees if possible. When we have to reoperate, consider completing 360 degrees or go to filtering surgery. Often, the patients will need multiple surgical procedures. And here we have, I like angle surgery. If I haven't treated the whole angle and there's a chance to treat it, I like treating it and repeating it. And if not, I just go and move to the next level, which for me, I prefer glaucoma drainage devices. In older patients, I would do a trabeculectomy of deep sclerectomy. And as a later resource, I like using cyclodestructive procedures. Thank you.
Thank you so much, Elena. This is a very nice presentation. It lays out all the options and you know, the stepwise approach. Let me ask you a question. So is the choice of primary procedure, in your opinion, only guided by whether the cornea is clear or not? Or is the pressure a factor as well?
Correct. That's a great question. So yes, the pressure is important in the case that I would say the degree of glaucoma, how advanced is the glaucoma. If we have a very small island, the pressures are extremely, extremely high. I am not sure this patient, if I do angle surgery, it's not going to work and it's going to jump up. I would be extremely careful on this case. I tend to always do angle surgery, but in those cases, we have to watch it very carefully because if we have a very advanced glaucoma, that spike on pressure can damage the remaining nerve that we have available.
And also in your talk, you mentioned that you would consider a second angle procedure if not the entire angle had been treated. But what if you had done a circumferential procedure and then, like, you know, in EUA and you found that there is cleft closure? Would you try doing another 360 degree or, like, you know, even a partial angle procedure in a previous angle that you had treated before?
Exactly. So a couple of years back, we tried to treat the whole angle. If it's treated, we move on. Right now, we had a lot of patients that we had a lot of success by retreating the angle again. But again, I would be careful. I would see how the time of between the first surgery until it has closed, how long has it been? I would also look again, how severe, how advanced is the disease. If I'm going to retreat, it's going to close, the eye is going to increase in axial length, and the neuropathy is going to progress, then I wouldn't. But in so many, we have many patients that we have retreated and we have success, so that's good. And the other thing is, like, a lot of times we treat as a primary procedure. We just don't do like a 4 hours goniotomy. We try to treat primarily the whole 360 just to start with, because the highest probability of success, we have it with the first surgery that we do.
All right, Dr. Elena, can I ask you, thank you for your very comprehensive talk. That's very, covered everything. About the circumferential redos, how far after the primary procedure can you go ahead with another circumferential? So if it fails like within 6 months, would you go ahead and repeat it? Or is it that you need some time for it to work? And then if the glaucoma recurs, you can go back and redo it?
So if it's 6 months, I would definitely go. If it's like the longer it is, if it has worked for like several months, absolutely, I would try in this case. If it has failed shortly after, I probably would not bother as much, as long as I know that I treated that nothing happened in the procedure, that I'm sure I was in the spot I wanted to be. So if it's a shorter failure, that there's not a reason that I think, so then I wouldn't. But 6 months after, yes. And in those cases, we have nice results. And a lot of times,
Right. So you.
A lot of times I go ab externo.
Go ahead, sorry.
A lot of times for those repeats, we like to go ab externo. Because it's
right, yeah. Okay, there's a question from Dr. Tariq Ragai on neonatal PCG, because these cases, they have the worst prognosis, the ones that you have to operate within the first month. So those with severe cloudy corneas, which is your preferred procedure to start with?
Ab externo trabeculotomy, and I like to try to go 360, which in premature kids is challenging, but still I do use an eye science catheter for that. So we can try to go 360 with a Prolin suture. I think it's trickier. I would try it in some cases, but I think having the illuminated catheter is a plus in this.
Dr. Bitrian, there is a very nice question here from the audience. And just enumeration, what is success? What is the success endpoint? What do you consider a successful surgery? It's not like adults, like 20% lower pressure lower than 21, and so on and so forth. So what do you define as a successful glaucoma surgery in a child?
So we do serial UAs. We check axial length, and corneal diameters. So it's a pressure that allows us for the eye to like slow down that growth. That's basically. And obviously we check the pressure, and obviously we check the nerve, and we take photos. So seeing that it doesn't change the nerve, seeing that the axial length, they are comparable. We compare with the other eye also, and we see like the typical charts that we have for progression of the axial length. That is a key for us. And it is okay to have a effect on the pressure, but not be enough, and needing some adjuvant medications afterwards, like having a trabeculotomy and having to be on like 1 or 2 medications. As long as the pressures are okay, that's okay.
Are there types of congenital glaucoma that do worse than others, and may end up in blindness or have a poor prognosis or poor response to surgery?
So there are types of glaucoma that have a poor response to angle surgery, and those are the secondary glaucomas, such as Stuch-Weber, Axel-Feld-Rieger, actually aniridia as well. They don't have as good success with angle, but we still do it because we have patients that it gains a bunch of, like some months, some years. And also after cataract surgery, so some surgeons would go straight to a fusion, but if we have give the chance for an angle surgery, often it can work, and we have patients that it has worked very nicely.
Right. One last question from the audience on combined trabeculotomy, trabeculectomy. Would you consider combining both in some cases?
So the thing is, I don't do as many trabeculectomies on small kids. I would do that on a juvenile open angle and someone older, and I think that's true for a lot of surgeons in the States. We tend to not do as many trabeculectomies on younger children. I do like the idea of combining procedures. So what we do is we do a trabeculotomy and a stage 1 barbell. Those procedures we do combine. In some patients that we anticipate, I want to give a chance for angle surgery, but I know this child probably has a bad prognosis. Maybe it has glaucoma that runs in the family, aniridia or something, and I expect it to need something else in the future. So then we put a barbell plate and we just tuck the tube underneath the plate, and we don't connect it to the eye. And then if that spikes, we take the child for surgery and we just connect it, and we have the benefit of the shunt without having to wait.
All right, thank you very much, Dr. Elena. There are lots of questions from the audience, but we'll have to move on to the next presentation. We'll probably go back and take those. So our next speaker is Dr. Hala Hilali, who is a professor of ophthalmology at Cairo University. Dr. Hala was the director of Pediatric Ophthalmology Department in Abu Rish Children's Hospital, which is the pediatric hospital of Cairo University, during which time she has proactively provided everything one can dream of in a pediatric ophthalmology practice, really. Introducing Dr. Hala is always a difficult task. We refer to her as our mentor, but she's much more than that. She's a truly inspirational person to everyone who's been lucky to work with her. She's a great surgeon in pediatric glaucoma, strabismus, and cataract, and she's a giver beyond imagination. And she also happens to tear up easily, so I'll keep it short and move on to the presentation.
This is
Get too
true.
emotional.
This is true, and you guys are really overwhelmed me by your introductions,
I
and
know.
it's exaggerated, but thank you.
That's our
Thank you
only
so much.
opportunity to show with how much, we are.
Thanks. So I'm very happy to be with such a distinguished group of people. And my talk today will include actually two procedures. The first one is the time-honored conventional goniotomy procedure. And the second will be the recent innovation, which is the ab interno trabeculectomy using the Kahoot dual blade. I have no financial disclosures. So the surgical principle behind the conventional goniotomy is to create an incision in the abnormal or dysgenetic trabecular meshwork for 120 degrees of the angle in order to facilitate the outflow of aqueous from the anterior chamber into Schlemm's canal. It has the advantage of being done directly under direct visualization, and the fact that it attacks the defective tissue, which is the abnormal or dysfunctional trabecular meshwork, directly. It does not jeopardize conjunctiva or sclera, which are very dear tissues for a glaucoma specialist because they may be needed for further procedures if this one fails. The disadvantages, though, are that it requires clear cornea. It incises only 120 degrees of the angle from a single incision site. And it leaves residual trabecular meshwork leaflets. It does not remove any part of the trabecular meshwork, it just incises it. In order to perform goniotomy, a prerequisite is having clear cornea. And one can try to clear up the cornea preoperatively using anti-glaucoma medications, but also intraoperatively at the beginning of surgery if the edema is epithelial. And that is done by removal of the central part of the epithelium. However, if the edema is stromal, that doesn't help very much. So the glaucoma setup was already discussed. The head is tilted away 40 degrees, and the microscope itself is tilted, and the surgeon sits on the temporal side of the eye that will be operated. For exposure, I personally prefer placing traction sutures under the superior and inferior rectus muscles, using 6/0 or 5/0 silk on a rounded needle. And when I place the traction sutures with equal tension, that sort of elevates the eye up a little bit, retracts the lids well for me, which is very useful in small palpebral fissures where a lid speculum would actually exert pressure on the eye and may actually increase the corneal cloudiness. If I find at the beginning of surgery that visualization is not adequate, a drop of 70% alcohol is placed on the central cornea, and then a dry microsponge is used to sweep the epithelium away from the central cornea, leaving an intact trim of epithelium at the periphery, and you can see that that does sweep away easily. This is the actual conventional goniotomy, and I use an irrigating needle, 25 or 27 gauge, attached via an IV line to an infusion bottle. This is the tip of the needle engaging the trabecular meshwork very superficially, and then moving alongside trabecular meshwork in the same plane to create the incision. I go first in one direction and then in the opposite, keeping the same plane, and you can see that the posterior leaflet of the trabecular meshwork as well as the root of the iris fall back. If bleeding starts to occur, you can raise the height of the bottle, and that will increase the pressure inside the eye and tamponade the bleeding. And at the end of surgery, the beauty about using the traction sutures is that you can get your assistant to hold them and help you rotate the eye, and you can get an extra 1 or 2 clock hours through that rotation. Here, I'm just testing to make sure that I don't have any residual remnants of TM crossing the gap. So blood trickles from Schlemm's canal into the anterior chamber at the end of surgery. The incision is sutured. I prefer to inject BSS in order to pressurize the eye. I don't use viscoelastic. I find that using it just pushes the blood back into the angle of the anterior chamber, which invites fibrin and adhesions. Operatively, the head is turned to the same side if it's a unilateral case. In bilateral cases, I don't do that. And when you turn the head to the same side, you're placing your goniotomy incision uppermost, and blood will trickle away from the site of the goniotomy incision. Steroid antibiotic eye drops are used, started 6 times a day and then tapered over 4 to 6 weeks. And of course, we need to watch out for steroid responders. Again, in the previous talk, it was mentioned that the angle surgery results, both goniotomy and trabeculotomy, are quite high. So the success rate reported in Western studies is between 70 and 90%. Worse prognosis is reported with more aggressive disease, longer duration, and marked enlargement of the anterior segment with structural damage. However, in studies coming out of the Middle East that evaluate conventional goniotomy results, the reported results are significantly lower in success rate. On the average, you can see here 3 of the studies coming out of the Middle East, Al-Hazmi and El-Sayed and Hassanin et al. And the average success rate of these studies is about 50%. And that points or is attributed to the more aggressive disease that we have in the Middle East. If you look again and analyze Al-Hazmi's results, you will find that the success rate is not uniform throughout the spectrum of the angle closure primary congenital glaucoma. You'll find that in mild primary congenital glaucoma, the success rate is 81%. And by mild, we mean cases where the preoperative intraocular pressure is less than 25, the corneal diameter is less than 13 millimeters, and we have good corneal clarity. And so if you adhere to good selection criteria, goniotomy does yield good results even in the Middle East. This is one of the studies coming out of Egypt. It evaluates factors associated with early and late failure of after goniotomy for primary pediatric glaucoma. It's a retrospective study that included 81 eyes, and the inclusion criteria were that to have a minimum follow-up of 4 years. The mean follow-up actually was 5.9. The mean age at surgery was 6 months. And cases were considered a complete success if the intraocular pressure was less than or equal to 18 millimeters mercury without meds, a qualified success if meds were needed. So the early success rate in this study was 69.1%. There were, however, 18.5% of cases failed after the first year of surgery. And the mean time to failure was 5 years after surgery. So the long-term success rate was 50%, and that really stresses the need to follow up these cases for prolonged periods of time, forever actually, to make sure that the pressure does not rise at any point in time. The risk factors for failure were positive consanguinity and surgery in the first month of life. And this is another study coming out of Cairo University Children's Hospital, where the failure rate was 56%, the mean survival time was 17.6 months, and factors that influence failure were pre-op cup disc ratio. An exciting innovation is the introduction of the Cahook dual blade, which was designed to remove to excise a strip of trabecular meshwork from the angle under direct visualization. The sharp tip of the Cahook dual blade engages the trabecular meshwork and creates the first or the initial incision. The heel of the instrument is then settled against the wall of Schlemm's canal, and as the instrument progresses through trabecular meshwork, the trabecular meshwork is stretched and elevated on the ramp of the instrument and is guided towards two sharp blades on the sides, and therefore two parallel cuts are created in the trabecular meshwork, and the strip can then be removed at the end of surgery. So by creating the two parallel incisions, you can see in the picture on the right side, a strip of trabecular meshwork is was actually detached from the angle. You can see the arrow pointing to that strip. This results in a near complete removal of trabecular meshwork and should reduce scarring and fibrosis of the residual TM leaflet. So after, this is a view of the surgery. After ensuring that you have clear visualization of the angle, clear corneal incision is created. Viscoelastic is used to inflate the anterior chamber. The KDB is then advanced across the anterior chamber, and the tip engages the trabecular meshwork, and this is the heel being against the wall of Schlemm's canal, and it is advanced through trabecular meshwork, and you can see that the root of the iris falls back. This is continued for about 100 degrees of the angle in order to open up the angle. Now, in order to actually remove the strip of trabecular meshwork, several techniques were described. The one I prefer is the mark and meet technique. So again, the incision, clear corneal incision is created. Viscoelastic is used to inflate the chamber. The KDB is advanced across the anterior chamber, and the first incision is created at the leftmost part of the visible angle. The Cahoog dual blade is then relocated 3 clock hours to the right of the first incision and is then advanced towards the first incision. And as it meets it, you will see that a strip of TM is produced. There it is. Now you can see that you can repeat that, moving more and more towards the right and then progressing leftwards towards the incised or the open part of the trabecular meshwork, and you will get several of these strips that can then be removed. This is a 23G forceps introduced into the anterior chamber, and it is used to remove the strip. Here the strip is dangling from the 23G forceps, removed out of the eye. This is another case, and I find that manipulating the KDB is best when I move in a forehand direction, not a backhand direction. So I'm always moving from right to left. The first incision is again created, and then I move more to the right. And here again, I'm moving towards the original or the first incision that I made. And you will see that by repeating that, several strips, again, you see a loose strip here on the surface of the iris, a strip of TM. Again, repeating the incision, moving from right to left. And here there's another strip of trabecular meshwork that's still attached at a point to the angle. And the Cahoog dual blade can be used to cut the attachment, and you can see it now dangling on the Cahoog dual blade. The 23 gauge forceps is used to remove the excised trabecular meshwork strips out of the eye. Several of those can be produced, and you can actually do a whole 100 degrees of the angle. So this is my take on KDBs. I find that using the KDB using the KDB in angle surgery actually controls the depth of the incision for you, because once you place the heel of the KDB against the wall of Schlemm's canal, you are controlling the depth of the incision unless you direct the tip of the KDB backwards, and then actually you'll be going too deep. If you position the KDB properly, flatly, on the against the wall of Schlemm's canal, and if it is not tilted, then you can actually excise a strip. But the thing is, if the Cahoog dual blade is tilted in any way, you will end up creating one incision by one blade, and then it becomes difficult to remove a strip. Now, the question of whether using the KDB is better than conventional goniotomy waits to be answered, and actually we're hoping to find that out from the study we're doing, where we're comparing conventional goniotomy to the KDB ab interno trabeculectomy. So why ab interno angle surgery is my choice? I prefer ab interno angle surgery always. if I can get away with it and if the cornea is clear enough for me to do it. It's done under direct visualization. It attacks the defective tissue directly. Again, it doesn't jeopardize conj or sclera. It does not prejudice the success of future surgeries if they're needed. It's less traumatic, it's safe, and it's short. So I can perform it bilaterally without worrying about neurotoxicity or the length of the surgical procedure. Thank you.
Thank you, Dr. Hera, for this very nice presentation. Would you consider doing a circumferential incision with the KDB as well, like going through 2 separate corneal stab incisions and covering as much of the angle in predisposed eyes for failure, I mean?
Yeah, well, actually, I have considered it. I think we can try that. But the thing is, I always find that if I'm entering from the nasal side, it's a little bit cumbersome for me. But I guess, yes, it can be used to excise more tissue or more trabecular meshwork out of the eye, and that may open up more collector channels and therefore improve the success rate. That needs to be, again, addressed or studied.
All right, so there's a question on what if the trabecular meshwork is not seen? And I think it applies to all panelists. What tricks do you use if you don't see the trabecular meshwork intraoperatively in pediatric eyes? Because that's quite common to have it covered with iris tissue or have it hypopigmented. So I'd like to know what the panelists do in these cases. Dr. Hera, do you want to start?
Yeah, okay. So we see that a lot in our cases in Egyptian patients where we have more of a wraparound configuration where the iris actually wraps around the angle and covers trabecular meshwork completely. Well, for these cases, I'm used to doing them with the conventional goniotomy. I just use the needle very carefully just above the surface of the iris insertion, and I make my primary incision, and I see that the iris and the actually what looks like a membrane at that point. It's a very thick membrane that's closing up that angle, which is the dysgenetic and compressed trabecular meshwork. So that starts to fall off, and you continue to do that very carefully, and that has worked, and I get really good results with that. My problem is actually with the visualization of the angle rather than how to address the angle anomaly more.
Yeah, it's actually very common in pediatric eyes. So I'm going to touch on these issues in my presentation. Okay. So it's very common, high iris insertion and the visibility of trabecular meshwork issues. So the common thing that I do usually during surgery, just to make the eye hypo and try to see the blood in the Schlemm's canal. This is a classical method to find where the canal is.
Right, great. Dr. Albert, you actually published on KDB in pediatric eyes before. I think it was it aphakic pediatric glaucoma? I think it's one of the very few publications, if not the only one, in pediatric glaucoma.
Yeah, it was actually in a child with glaucoma after cataract surgery, and so I could see the TM pretty well in that child, so I used the KDB. But I agree with what Dr. Hala just said and what Zainab said. Sometimes the iris is so high up, the KDB is about, if I remember right, and side as high up as possible and tease the iris down. So you can't use a KDB on all eyes, obviously, only on select eyes.
Dr. Hala, my question to you, in ordinary cases, do you really find that removing a segment of the trabecular meshwork would make a difference compared with just incising the trabecular meshwork in conventional goniotomy?
That's exactly why we're doing the study, and I'd rather wait until we have our results. I'm not sure whether removing a block of tissue would make a difference. My personal experience or my feeling is that the more the circumference of the angle that we open, the better, because we're getting more access to more collector channels this way, rather than removing a block of tissue. But I'll keep that until we have all our results out. But that's my impression.
We have a lot of questions from the audience as well. So if you can go over them and see if you can answer any of them. Dr. Hela, thank you so much. Really,
Thank
now it's another very difficult task of mine, which is to introduce my dear friend, Dr. Yasmina Sayed, who's a professor of ophthalmology at Cairo University and who's also glaucoma consultant at Abu Rish University Hospital, which is the pediatric hospital of Cairo University at Qasr Al-Aini School of Medicine. And, one feels really proud that someone of Dr. Yasmin's caliber is serving our community in Egypt and the region at large, and doing this world-class, advanced and intricate work for our pediatric glaucoma patients. So Yasmin, go ahead.
Thank you, Mohammed, for this very nice and that's very kind of you. So I'm going to be addressing the ab external trabeculotomy. I don't have any financial disclosures. So angle surgery, what it does in pediatric eyes is that by incising the angle, you improve the facility of outflow, just like in adults. But in addition to that, it allows the peripheral iris to fall back away from the angle as an additional effect specific to PCG patients. And so the angle widens, and that improves the access to the collector channels and distal outflow pathways. This can be performed through an ab internal approach or an ab external trabeculotomy. And the traditional ab external trabeculotomy is performed with the rigid probe metal trabeculotomes, where you identify the Schlemm's canal and then you connect it to the anterior chamber over 120 to 160 degrees. The success rates have been variable depending on the duration of follow-up and the different populations studied. And again, I'm quoting Al-Hazmi's paper because their population was closer to ours. So that was a retrospective study in Saudi Arabia that looked at the results of trabeculotomy, 418 eyes, as well as goniotomy over 10 years. And they found that the success rates dropped significantly the more severe the glaucoma was, which makes sense. We also looked at, from Abu Rish Hospital, ran this study that looked at factors that influence the outcome of goniotomy and trabeculotomy adversely. So we looked retrospectively at patients that have had angle procedures over 4 years. There were 120 goniotomy eyes and 332 trabeculotomy eyes. Trabeculotomy eyes did far better than goniotomy, and their survival was longer. And the shaded cells here show the factors, the adverse prognostic factors that have led to less IP reduction and more failure with trabeculotomy. And more specifically on multivariate analysis, female gender was found to be significantly correlated with more failure and less IP reduction. Patients born to consanguineous parents, a younger age representation were all poor prognostic factors, a high preoperative IP, and finally cornea that is opaque. These were all poor prognostic factors for trabeculotomy. And interestingly, in this study, we found that 62% of our cases with opaque corneas cleared up after trabeculotomy, and 1/3 of the patients had reversal in their cupping by 0.2 or more, which really gives an idea how visually rewarding this field is, unlike what it's the reputation for everyone that's considering a career for pediatric glaucoma. It is actually a very, very visually rewarding specialty. And so the idea of trabeculotomy, the main step is to accurately locate Schlemm's canal. And according to the different publications, in 4 to 24%, the canal may not be found, either because of the abnormally stretched limbal anatomy. The canal itself may be obliterated, especially in advanced glaucomas with very high pressures. It may be discontinuous, but there's an important factor that's related to the learning effect of the procedure, being a blind procedure with a high risk of creating false passages. I'm quoting Al-Hazmi's paper again here. The authors reported that the success rates of their trabeculotomy cases increased from 29% to 82% over the 10-year study period. In other words, these early cases of trabeculotomy that were considered actual trabeculotomies were what we call pseudo-trabeculotomies. They went into the false passage, and so they resulted in a worse outcome. So you'll be surprised how many wrong passages can be around the Schlemm's canal, where the probe can go in smoothly, but then at some point you realize that this is not the correct plane. So here I found myself interested strongly in risk creating a decimate detachment. And always in these cases, the main thing is to detect that timely. So when I redirected the dissection posteriorly, in this case, and I probably was able to locate Schlemm's canal and complete my incision into the anterior chamber. You can find the probe sometimes behind the iris, or one of the very common mistakes is to perforate the floor of Schlemm's canal and get aqueous directly from the anterior chamber. And the trick here is to spot that timely, because obviously, as in this case, where a resident was operating, there's a gush of fluid that is more than what you would expect from the canal deroofing. And as you can see on this side, he did not create a trabeculotomy. He completely bypassed the Schlemm's canal with the probe, creating what we call a pseudo-trabeculotomy. So the main trick for to improve the success rate is to locate Schlemm's canal properly and remain inside it with whatever you're using, whether the suture or a microcatheter or the rigid probe trabeculotome. And one of the tips we use, and we've come to doing after we started using the microcatheter, is to deroof Schlemm's canal. So it helps to visualize the floor, make sure that it's patent, make sure that this is actually Schlemm's canal and not the wrong plane. And this video demonstrates the importance of that. So my probe, as you can see, is moving very smoothly without any resistance. And then when I started deroofing, I realized that the whole floor was shredded and the uveal tissue was prolapsing. So I would have proceeded with my usual trabeculotomy, thinking that it was an actual trabeculotomy when it wasn't. And deroofing also can help you detect a tear in the floor. As you can see here, there's a brown line there that denotes a tear in the floor of Schlemm's canal, and you can still avoid that and bypass it and complete a successful trabeculotomy by avoiding the tear that you can directly visualize. One of the sure signs is to see the strip of trabecular meshwork in the anterior chamber. If you're lucky, this doesn't happen all the time. But if you get that, then you're quite sure that this was actually a correct passage. So again, with circumferential trabeculotomy, there is a growing evidence that it is superior to limited extent 120 to 160 degree angle surgery, whether goniotomy or trabeculotomy. And none of the studies that have shown superiority of circumferential trabeculotomy have shown that it's more likely to complicate. And as you can see here, there's a significant difference in success rates. We've published a study from Abu Rish Hospital on a prospective randomized trial comparing the microcatheter-assisted trabeculotomy with the glucolite microcatheter back then, compared to rigid probe trabeculotomy, and the success rates were remarkably better for the circumferential technique. And the first to come up with a reproducible technique for creating circumferential Schlemm's canal incisions were Beck and Lynch back in 95, where they used a proline suture with a tip blunted out with cautery, and you basically insert this through one end of the Schlemm's canal and keep on threading it until it reappears from the opposite side. Of course, if you have a clear view of the angle, you can visualize that with a gonial lens, make sure that it's not gone into a false passage. But if you have a cloudy cornea, then it becomes a completely blind procedure. So obviously there's a risk of creating false passages with that, and it's been reported in a few studies to have caused, to have become misdirected into the suprachoroidal and subretinal spaces. And so with the introduction of the microcatheters, namely the iTrack and the previously available glucolite, this risk of creating false passages has been markedly reduced, because the microcatheter allows you to visualize the tip as it goes circumferentially, so you can keep track of it, and whenever it stops on the way or becomes misdirected, you can always stop and identify where exactly that happened and address the problem at its site. The problem with the microcatheter, of course, is the cost and availability, which is something that we all need to consider at the moment. So what we've shifted to doing over the past 2 or 3 years is the two-side trabeculotomy technique. So this technique has been described before for trabeculotomy, and what you do is you create two trabeculotomies simultaneously in the same sitting. Usually the first one is based on the supranasal quadrant to avoid the superior and supratemporal quadrants in case you need a bleb-based procedure later on, and the other is 180 degrees from that, so that's usually based on the infratemporal quadrant. And it's always important to make sure that your probe is going in parallel to the iris, parallel to the limbus all through, so it wouldn't become misdirected anteriorly and risk opening the anterior chamber prematurely or posteriorly and create a suprachoroidal or seriochoroidal effusion or cleft. And we retrospectively compared the results of our two-side trabeculotomy technique with the microcatheter-assisted trabeculotomy, and we found that the cases were comparable in terms of success rate and IP reduction. In fact, the two-side technique yielded better results in terms of success, but the difference was not significant. We had a few observations about using the microcatheter back then, and I have to stress out that this was the glucolite. We're just starting to use the iTrack recently, but it used to be the glucolite back then. And as you can see here, although you can visualize the catheter, there were some puzzling cases. So in this case, for instance, although we could visualize it and we're expecting it to reappear from the opposite side, having rotated circumferentially, it became misdirected at some point posteriorly, and that required the scleral cut down to retrieve it. We also noticed that compared to the rigid probe trabeculotome, microcatheters being thinner do tend to penetrate the anterior chamber sometimes prematurely, and this is demonstrated in this case. So this patient had bilateral PCG. I operated on one eye, and my dear colleague, Dr. Ghada Gaudat, operated on the other eye, and we both had the same experience. So while cutting or pulling out the microcatheter, we did not feel any resistance corresponding to the incision in the anterior chamber angle, and the pressure did not drop a bit post-operatively. So it was really puzzling, and we thought the only place where the microcatheter could have gone would be the angle recess, but it would be really strange to be able to rotate circumferentially and still remain in the angle recess. And then I got an answer to this, or a confirmation recently, a few weeks ago, when I was doing a case of GAT, and as you can see here, the suture went in early on nicely into the Schlemm's canal in at least 1 or 2 quadrants, and then as I kept pushing, it reappeared from the opposite side, but it was completely outside the Schlemm's canal, having penetrated at some point at least 1 quadrant before it arrived there. So it can happen, although you can visualize these microcatheters or sutures, but they can penetrate into the anterior chamber and give a false passage. One last thing with the microcatheters is that in around 30 to 40% of cases, the microcatheter stops on the way or becomes misdirected, and you need to create a scleral cut down to retrieve it, and often you need the help of rigid probe trabeculotome to complete your incision. So we thought, well, if we're using the trabeculotome anyway, so why not just start doing the two-side from the start and maybe save some fiddling with the microcatheter and as well as some money. Finally, the microcatheter-assisted or circumferential trabeculotomy has been shown to yield very good success rates after previous incisional glaucoma procedures. And we've been doing the two sides in those cases because it gives us the easiest access to the Schlemm's canal. So even after tube cases where we would have proceeded to do a possibly diode cycle photocoagulation, or patients who've had a previous TRAB, especially patients who are referred to us with a primary trabeculectomy for pediatric glaucoma, for those, instead of escalating to the next level of treatment, which would have been a tube, we go back and do a circumferential trabeculotomy. And finally, as Dr. Elena was saying, the success rate in secondary glaucomas is less than PCG, of course, but in aphakic glaucoma, it does really a great job, and it has really revolutionized the treatment of aphakic glaucoma. So Sharon Friedman has reported a 72% success rate with the illuminated microcatheter in aphakic glaucoma. So one last word during these challenging times of COVID, the one thing to look for these days this really is the silver linings. And there's so many. It's the only way to really stay sane during these difficult times. And for me, at least, of course, one obvious silver lining has been to edit my surgical videos, which is something that I've intended to do after my retirement and got a chance to do it earlier. But the other silver lining really is getting to meet all those experts from around the world and in these webinars and exchange ideas from the comfort of your living room. And it's been a really mind-blowing experience. So I'm happy for that. And thank you. Stay safe.
Yasmin, thank you so much. This was an incredible presentation. I loved your videos and like the surgeries and all the tips, and the videos are really high quality. Let me ask you, because I ran into this you know, a couple times. So how do you manage Descemet's detachment if it happens in the context of as a complication of trabeculotomy?
Well, luckily for now, it hasn't been very extensive. Like, we have a very peripheral, very limited Descemet detachment, the one you get on a phaco case, you know, at the small ones. But if you recognize that timely, so the trick is to stop before it happens, rather than proceed and then create it. But usually if the probe is at the intrastromal level, it would stop proceeding, and no matter what you do, even if you force it in, it wouldn't go in. So unless you're really insistent and persistent, which is something that I don't think anyone would do.
And the question that Elena has answered herself before, do you see a role for combined trabeculotomy, trabeculectomy?
I don't really believe in that. I think if the combined trabeculotomy trabeculectomy will work because of the trabeculotomy part. And I think the trabeculectomy, if not only doesn't add much, and I think it just reduces the success of trabeculotomy by shadowing of the anterior chamber a bit and directing the flow into two separate directions instead of having all the aqueous coming out of the angle. So it might, but this is definitely very anecdotal, might increase the risk of scarring of the trabeculotomy over the longer term.
And also, so when you do a ab external trabeculotomy, does it always have to be in a patient with an opaque cornea? I noticed some patients actually in the videos had clear corneas. So
these are older, yeah, you're right. These are older videos because we're shifting to GAT recently over the past year. But there are some pediatric eyes where you can't locate Schlemm's canal even if they have a clear cornea. And I have a low threshold to do an ab external technique, especially that I'll keep it away from the superior and supratemporal conjunctiva. So if I don't get a very clear view of the angle, I don't really fiddle and struggle. I just go for an ab external. But for patients with clear cornea now, including the aphakics, we definitely go for GATs.
Thank you so much. And Dr. Grudzinski, if you can unmute yourself, I know firsthand the case that you did of Peter's anomaly that had iridocorneal attachments in which you did an ab external trabeculotomy. How did that go?
Well, you know, it's a little bit, it's a little scary at first because you do the typical ab external trabeculotomy. I used a microcatheter on my Peters anomalies, go all the way around, but when you pull it through, you know, Yasmin, you were talking about Descemet's detachment. That's a big fear because you have these attachments and you're pulling on it. You can actually see a tent. And if you go simultaneously and deepen the chamber with a viscoelastic to pull away while you're pulling through, it will break the attachments as well as doing the 360 trabeculotomy. And it's interesting because I noticed on some of your videos, iris prolapsing after you pulled through. Well, that's something we want to happen in Peters because at that point, since the central cornea is opaque, we do a very large optical sector iridectomy. And I call it the 3-in-1, you're done, because you've done the angle, you've broken the adhesions, and you've done a big sector optical iridectomy. And I have found that to be very useful. I've been asked, what would I do if I had detached the Descemet's? The cornea is already opaque. So I'm not too afraid of that. But if I do successfully break the adhesions, Peng Ka has reported it, and it's certainly been my clinical experience, and I think Elena's as well, that the cornea will clear over time. So it's maybe I've been just lucky.
So actually, I can't find that video on my computer, unfortunately, but you know, I actually have a few pictures of pre and post-op and how the cornea cleared. So, you know, if this is not going to delay us too much.
Yeah, please go ahead. Yeah, is that the one you posted, Mohammed? Did I watch that?
Yeah, it was posted.
Yeah, that was a great. Yeah, that was a brilliant video.
And then, so this is a picture. I'm going to share my screen. So this is the pre-op photograph from an EUA. And this is the pre-op UBM. And this is the post-op UBM after all the iridocorneal attachments had been broken with the microcatheter.
Mohammed, we're seeing small icons here.
Oh, really? Okay. So I'm gonna actually prepare them.
Okay, great. Yeah.
Yeah.
Maybe after Zainab's presentation, that would be great.
After Zainab's presentation.
Yeah.
Okay. Thank you so much, Yasmin.
Thank you so much. So the next talk is on GAT by my dear friend, Dr. Zainab Aktes, who's an associate professor of ophthalmology in Gazi University in Ankara. Actually, this webinar was Zainab's idea from the start, and she's greatly helped organizing it. Zainab did her clinical ophthalmology fellowship in the University of Wisconsin in the US, where she worked, amongst other things, on developing gene therapy that targets the trabecular meshwork and Schlemm's canal. We both share the passion for the anterior chamber angle, and she's one of the leading figures in the GAT movement that's been taking the glaucoma world by storm. So Zainab, would you like to present your GAT presentation?
I'm trying to share my screen, sorry. You see my presentation? Do you see my presentation?
Yes, we do.
Okay. Now, hi everyone, it's a great pleasure to be with you, all experts from all over the world. It's a great pleasure. Now I'll be talking on GAT surgery in kids. Right now, I have no financial disclosures, so I'm gonna give some surgical pearls, and I'm gonna touch on some difficulties in pediatric eyes in these clinical situations, as you see here, right below. So in our clinic, we usually take as a guide these guidelines from World Glaucoma Association and Child Glaucoma Research Network. So at this point, I would like to thank, first of all, Elena for her dedicated work for years and for her being a role model for all of us. Thank you. So as previously mentioned, angle surgery is the first choice of surgery in kids with primary congenital glaucoma. And we try to make it circumferential as much as we can, because we know that circumferential surgery is has a more successful rates over the traditional one. So unfortunately, in Turkey, in our geographic area, we mostly have moderate to advanced congenital glaucoma cases. So it's not quite easy to do GAT in all of the cases because of corneal edema. So whatever it is, we try to do it circumferential. So it's also a safe surgical procedure and also more successful procedure. as I said. So in cases with clear corneas, we can go ahead and do gonioscope-assisted transluminal trabeculotomy. It's sort of an internal version of circumferential trabeculotomy. So in this picture, you see what we are using during this procedure. You don't need to use too many instruments, surgical instruments. All you need to do is to have a surgical gonio lens and some sort of surgical gonio lens with or without handles, and you need cauteries and MVR blades and forceps. And I prefer to use pro-lens sutures. Of course, you can use a catheter if you have, but it's the cheapest way to do this surgery. So we have a lot of experience in adults, and this actually helped us to shift this GAT surgery in pediatric population. So first paper came from my friend Devender and his team from Texas, and they reported their results in cases with primary congenital glaucoma and juvenile open-angle glaucoma, and reported the reduction in intraocular pressure from 27 to 15 millimeter mercuries, along with the reduction of mean number of medications. So this is quite good results, and this can be considered a clinical success. So let's start with a case with a primary congenital glaucoma. She was referred to our clinic for surgery. As you see here, there is an increased axial length here in the right eye, and increased IOP, and along with increased corneal diameters. And as you see here in the bottom, she has also descending membrane breaks, which is typical of primary congenital glaucoma. Before moving on the surgical video of this case, let's remember what kind of problems we have in those eyes. We have cloudy corneas, and this is a problem because it obscures our perfect surgical view. We have less pigmented trabecular meshwork in kids, as it was questioned before from the audience, and it's another problem to find for finding Schlemm's canal. High iris insertion is another problem, and in suture or catheter might frequently stop in those dystonic angles. So in these pictures taken in OR, you can see the flat iris insertion, which is typical of primary congenital glaucoma. You can also see the high cup to disc ratio in the right eye in this case. So let's go through the surgical steps. We basically, as previously mentioned before, we basically sit temporally of the patient and tilt the head and the microscope. Here you see the blood in the Schlemm's canal, and this really helps us to find Schlemm's canal in unpigmented, less pigmented pediatric eyes. And you see here how cloudy cornea affects our surgical vision. So we are creating 1 to 2 millimeter goniotomy here, and I kind of slightly pushing the posterior lip of the goniotomy incision, which is called trabecular shelf, just to see where you are. You should have seen the bright white posterior wall of the Schlemm's canal in the video. Now you grab a pro-lens suture. My preference is 5-hole pro-lens suture. As I mentioned, it's tend to stop in the Schlemm's canal, so you might need more rigid material in the Schlemm's canal to overcome these obstructions. And this is the case here actually. And when it stops, you should stop too and check the angle with the gonio lens and try to see the suture tip, the bulb. And if it's correct position, you can kind of slightly pull and try to push it again. And we made it here in this case. And then you grab the distal part of the suture and slightly pull it all the way around, and slowly pull it all the way around gently. So this is the basic steps of the procedure. And here you see the post-operative, early post-operative picture of this case. So another problem is high iris insertion and sometimes bleeding in these angle procedures. So in this case, as you see here, iris is highly inserted, and of course you might need to take the iris back using your surgical instruments. It might be a blunt surgical spatula, as you see here, or you can whatever you feel comfortable with. You can use some surgical forceps to grab and pull the iris slightly. And during these surgical maneuvers, you should use your instrument gently. So these vascular structures over the iris, as you see here, might bleed sometimes, and in the reflex bleeding from the angle is a common situation. So these hammers might create trouble sometimes, and if this happens, you can stop. You should stop and go ahead and irrigate your anterior chamber for a couple of times and inject viscoelastics. And this is how we handle how we handle this situation here. You see here in this video, and it's stopped in the canal as you see here. Now I try to make it circumferential, make it all the way around in another way, and we made it here. Okay, so let's move on to glaucoma associated with non-acquired systemic disease. This is Sturge-Weaver syndrome, and it can be classified in this group. In patients younger than 3 years of age, as we all know, angle dysgenesis is a possible reason for glaucoma in this case. There might be a couple of mechanisms, of course, as we know. So the angle surgery makes sense in these young eyes. So there might be persistent hyphema or sometimes vitreous hemorrhage reported in this case in the literature. These are quite challenging cases. So in this case, we're doing angle surgery since this patient has an angle dysgenesis and its cornea is cloudy, as you see here. And these are reflux bleedings from the episcleral veins. Actually, it's more than I expected here. Now, now I'm in trouble actually here. Maybe I can stop, but I keep threading the suture all the way around. I keep pushing it here in this surgery. Now then I realized that the suture, the distal tip is already in the anterior chamber. It's a kind of false passage complication. You know, it's misdirected in the anterior chamber in the superior quadrant. So I grab the distal part and keep pulling the suture, now tearing up the inferior part of the angle. So it means that we did 180-degree goniotomy here, and I decided to stop here since there's a risk of hyphema more than I expected, and stop and ended the surgery so that we can go for and plan handicap in those types of patients. Actually, that's what I tend to do in cases. This is a post of 6 months appearance of these pictures of these cases during the EUA. You see here there's a broad peripheral anterior synechias, and in the rest of the angle, trabecular meshwork is open. You see here the posterior wall of the Schlemm's canal, and this patient is doing great. So what about glaucoma associated with acquired conditions? So this is a case, 7-year-old kid with Behçet's disease and steroid glaucoma and cataract. So we are planning to do combined surgery here. When it comes to combined surgery, usually angle surgery comes first because of the risk of corneal edema. This might obscure your surgical view, of course, as you might guess. So this is a nice trabecular meshwork pigmentation, as you see here, grade 2 to 3, and you see here the nice posterior wall of the Schlemm's canal, and this is a 5-0 Prolens suture. And we keep threading the suture all the way around, and we're done with the 360 trabeculotomy, as you see here. And now it's time for less aspiration. So I would like to show you these reflux hemorrhage. This is actually what we would like to aim for. We want to see these blood reflux. So this means that your distal collector channels and your distal system is functional, actually. And once we're done with the cataract surgery, I would like to show you the flow. There's a definition of like episcleral venous outflow here in adults. You can see it here. When you open the irrigation, you can see the bleaching all the way around the limbus or parallel to limbus, or sometimes you can see the flow in the episcleral veins. The extent of this flow is very well correlated with the IOP reduction in adults, according to our study and other studies and other trabectome studies. But there's no data in kids' eyes, so this is maybe a subject to investigate. So GAT surgery might be performed as a salvage procedure. How? Let's see that. This is an 8-year-old boy with primary congenital glaucoma with a tooth trap, with a history of tooth traps, and still has glaucoma, and referred to our institute for tube surgery. And here we are checking the angle, and this is what we should do in all cases, of course. There are some synechias in the superior quadrants, but all the way, but the rest of the angle looks okay. So we go ahead and do inferior gonio surgery, inferior gut in this case, instead of putting the tube in. So in those cases, you can expect that suture, once you're done with goniotomy, suture might hit those previous scarred areas and get stuck in those areas. or once hit those areas, it might enter the anterior chamber, misdirected, or it might go posteriorly through the peripheral, through the PI. These are important points to be kept in mind, actually. So this is the case here. We keep pushing the suture, and it stops right here at the previous surgery area. So it doesn't mean that you have to, it doesn't mean that you are not successful. All you need to do is just to pull the proximal part of the suture. You don't need to grab the distal part. Actually, you just take the advantage of it when the suture gets stuck in the canal, and pull the proximal part and do gap surgery. And this is the post-operative appearance of the patient, and he's doing great without any medication. So it might be done also in post-PPV eyes and high-risk eyes. And how we do this, so let's see. This is a patient, he has a history of trauma, 13-year-old boy, and history of PPV and silicone oil removal. And now we have silicone particles in the anterior chamber, and you see the staphylomas, and you see the scars in conjunctiva. So it's hard to do another surgery, in a tube surgery or diode laser application in those eyes. So this is a challenging situation. And then you can just basically check the eye and then do the same procedure in those eyes. But these cases might need more medication. So he's doing great with 2 anti-glaucoma medications right now. You see the reflux here. And this is another case, and I love this case. So I learned a lot from this case, actually. And this is a baby with persistent fetal vasculature, and he has a history of lens-sparing PPV and still has a glaucoma. So as we all know, in the posterior PVF, lens-sparing surgery is indicated in those cases. And as a glaucoma surgery, actually, as a glaucoma surgeon, we just don't like to see a phakic patients, of course. So it's great. So glaucoma might be seen in phakic patients also, so since they are both developmental disorder. And since the angle is open, so doing gap surgery makes sense in this case. Actually, I'm so lucky to work with talented and distinguished surgeons, pediatric retina surgeon in our clinic, Dr. Özbek. This is her patient, and we are working together. We have similar lots of cases, and I learned a lot so that I have a chance to follow and treat those patients, and learning a lot day by day. So thank you. So gap surgery might be an option in those cases if the patient is phakic. So so in the last part, I would like to emphasize a couple of more points. As I told you, as I mentioned, in those cases with PIs, with filters, we should look for iris movements, and we should check the suture's position in those cases, because suture might go to posterior segment through PI. This is the case here, and I go for superior quadrant first. And this is a mistake for now. When I think the case, I should have gone for inferiorly. And now I'm going superiorly, and suture keep going and keep going and keep going. And I stop here and decided to check where I am, where's my suture, and what happens while pulling the suture back. As you see here, there's a pupillar peaking and iris movements here, because it was just right behind the iris. It was in posterior segment. So we should keep this point in our minds. And we should also look for the suture during gap surgery. It's not that blind as we do in ab-externo gap surgery. In ab-externo trabeculotomy surgery, circumferential surgery, sometimes we need to follow the tip of the suture, as you can see here, through the stippler. But during gap surgery, it's not that blind. You can just go ahead and put the lens over the cornea, and you can see where you are. So hyphema is one of early post-operative complications. It's not just a complication. It happens very frequently, almost more than 1/3 of cases, and it's a good prognostic sign, actually. And this is another last complication I would like to mention: supraciliary fluid with transient myopic shift. This is a kid with juvenile open-angle glaucoma, as you see here, presented with a shallow anterior chamber, and then it resolves spontaneously. This was another case. This is an adult. So, as a take-home message, I can say that gap surgery is safe, and also cost effective in kids if you're using suture, and it can be applicable even after multiple intraocular surgeries, including filters and including vitrectomies, etc. And it has a learning curve, but it's teachable, and now it's being performed all over the world. And of course, GAT surgeons should be should be comfortable and should feel comfortable with angle anatomy, and of course operating with gonio prism. So this is the end of my presentation. I would like to thank you all for your attention. Thank you.
Thank you, Zainab, very much for this amazing presentation, amazing videos you have there. Yeah. Okay, so my question is, do you feel that you do both GAT and ab external circumferential trabeculotomy? Do you feel that one is, in terms of IP lowering, more effective than the other? Because I get the feeling that ab external trabeculotomy, although GAT definitely is the procedure of choice if you have a clear cornea, but that it lowers the IP a bit more than GAT.
So you feel that
it's just a feeling I have, yeah. Maybe because there's some false passage where the fluid will go into the supraciliary space or something, whereas with the GAT, because you can directly visualize, it's strictly speaking an incision in the trabeculum.
So you want me to compare ab external circumferential and GAT surgery?
Yeah, I just want to know if you feel the same way about it, or is it just, you know?
Actually, we did it.
In any study.
We try to compare it actually, but in external, actually I start doing this surgery with in adults with external circumferential surgery, and we try to compare them actually at the very beginning of the cases. But in ab external cases, you don't know how pressure lowers. Sometimes there might be leak, under the sclera flap during the external surgery. But in GAT, you only have a distal collector channel resistance. So these are totally different surgeries.
Yeah. Mm-hmm. Exactly.
But I found GAT surgery very useful and very efficient in almost in every cases with open angle, even in advanced cases.
Yeah, totally agree with that. Now, the hyphema is an issue with GAT, but do you find it as bothersome with pediatric eyes as it is with adults? Because I know you do both.
It somehow occurs less in pediatric eyes.
Mm-hmm.
I didn't.
Yeah, that's interesting. Anyone has a thought on that? Why it would happen less intensively with pediatric eyes? No. Okay. Any questions from the panel?
Maybe it's the different pathogenesis of primary congenital glaucoma and adult open angle glaucomas. Maybe this is something related to that. I don't know.
Yeah.
Mm-hmm.
Actually, I'd like to hear Albert's opinion about that. Do you feel like, even though we're basically doing the same thing, but do you feel that like the ab internal and ab external approaches cannot like lower the pressure or work in any different way in terms of like mechanism or like surgical anatomy?
Yeah, my internet connection seems to be a little choppy. You broke out a little bit. We're talking about ab external trabeculotomy versus GAT.
Yeah. Do you feel there is any like sense of like whether they are different or not?
Zainab touched a little bit on, you with the external approach, you'd likely have some filtration there. When I worked in Saudi, the go-to was actually a trabeculotomy, trabeculectomy approach, which Yasmin talked about earlier. Do know in children, anything within maybe a couple of weeks. So whatever external component you have left subconj wise will probably go away if you don't use mitomycin. Now, whether there is an intrascleral lake or some suprachoroidal drainage in the external approach inadvertently or because of the technique, that's also another question. And unless we have UBMs or we are able to examine that, I guess it's very hard to answer that question.
Yeah, we need image of patients. it's hard to know what's going on in kids, but yeah, we can do it in adults. Whether there is a lake on in the sickler or not, there might be a mechanism. So I totally agree.
Thank you so much, guys. And now to our next speaker, Dr. Ilana Grajewski. So I've been fortunate to train under Dr. G. She has been an amazing mentor to me and many, many others. Dr. Grajewski is a world-renowned pediatric glaucoma specialist. She's a professor of ophthalmology at Bascom Palmer Eye Institute and director of the Balkan International Pediatric Glaucoma Center. She's also the founder and director of the Childhood Glaucoma Research Network, which has members in more than 40 countries. She has trained an army of fellows who are now fighting pediatric glaucoma around the world. Dr. Grajewski, please.
Well, thank you, Mo. But before I share my screen, I wonder if you could share your screen, if you have those pictures that we could see from the Peters anomaly. Do you have that?
Yeah. I put them on a PowerPoint, so hopefully they work better now. Do you see my screen?
Well, we do now, yes.
Okay, so yeah, this is the pre-op if you want to talk about it.
So this baby, I was shocked when, this is from the first exam under anesthesia, and both eyes had central corneal opacity, but honestly, I was shocked. Can you go to the next slide there, Mo? Let's see.
This is the fundus.
Yeah, the view, not a great view, right? Go ahead, next one.
View.
And these are the UVMs. I was shocked when I saw this because this made the diagnosis of type 1 Peters. And I was hoping it was primary congenital glaucoma, but when I saw this, I thought, oh, darn. Go ahead, Mo. Let's see what we have.
This is the poster.
Yeah. How long after surgery is this, Mo?
This is 3 months.
Okay, so what we did during surgery was what I described earlier with a 360 ab-external trabeculotomy and pulling through all of the adhesions that you saw to the cornea, and you can see how much clearer the cornea is now. Part of that could be the wonderfully low pressure now. I think we have a UVM after that, Mo.
Yeah, this is the fundus picture. Yeah.
Look at those beautiful nerves. That makes me happy.
Yeah. And this is the UBM. All the attachments have been severed.
And I'm sure the people on this panel have seen where they break attachments, whether it's Axenfeld Riegers or whether it's Peters. But it's amazing how much the cornea can clear. But in the interim, you still need to have that baby seen. So you need to do those large optical sectors at the same time.
Correct. All right, so I'm gonna stop sharing my screen right now. And please go ahead, Dr. G.
Let me find my screen. Okay, now where is it?
Oh, I'll come. 1 second.
Thank you. Oh, thank you. Let me go back a slide. Okay, so that was another technical difficulty. I think we've been having a few today, although I've really enjoyed everybody's presentation. And obviously, Mohammed is here with me at the Balkan Center at Bascom Palmer in Miami. So to start with, before we talk a little bit about the indications, I just want to say that I was so happy as I listened to everybody that we agree with each other. Because honestly, I think we all pretty much said you start with angle surgery first if you can. And I agree with that. Even in cases like Peter's, I will still start with angle surgery. There are some times when it takes a lot of nerve to start with angle surgery, aniridia being one. I still do angle surgery before going to a tube and Axenfeld-Riegers, depending on how the angle looks. And then, and also, I also, similar to the other panelists, start with angle surgery in glaucoma following pediatric cataract surgery. And certainly in some anterior segment anomalies, as Mohammed showed the slides of one of my type 1 Peters. And, okay, let's see if I can switch the slide. It's as if my keyboard has died. 1 second here. Here comes my trusty assistant. No. How did you do it?
With the arrow. With the,
but it didn't work.
It will.
It will. It's going to work. Okay. So how are shunts? We all do lots of shunts. Those of us who are glaucoma specialists, we do tons of these things. But it is so different in kids. And I think Elena started off with saying adult surgery is not equal to ped surgery. It is not adult surgery done small. There are so many things that are different. The axial length, if it's a small eye, if it's a large eye, it got that way in an abnormal way, and the sclera is very thin, and you have to keep that in mind. Although I have to say, once you're doing shunt surgery, you keep it in mind, but it's not going to affect too much other than where you initially place your tube. And then one of the critical differences, you have to remember that this is a time, especially in those children that are under the age of 3, that the eye is going to continue to grow. And I think this is the biggest mistake that is made by glaucoma surgeons who think, it's just a tube, it's just a shunt, let me just go ahead and do it. And the problem is where the tube is placed, how long the tube is, where the plate is placed, is all affected by the growth of the eye. Some of the other things that are unique can happen in adults as well, though, occluding of the tube. But I would also say that the face of children, which change, and the anatomy of the orbit, because the orbit is not completely, the orbit is not completely formed. So how does this help you? So you have to first then also make a choice on what type of tube are you going to pick. Is it a valve? Is it non-valve? And then the positioning. I think for valve versus non-valve, I tend to be like Elena and tend to favor bar valve because I think I get a lower intraocular pressure in the long run because of the larger surface area than I do with an Ahmed valve. And the placement of it, again, whether it's superior temporal or inferior nasal, sometimes depends very much on the child and what I'm dealing with. So if it's a child with a very flat face, flat orbits, it's awfully hard for it not to be visible inferior nasal, and I will always go superior temporal on those kids. The other considerations, depending on where I am, whether it's fornix or limbus-based conjunctival flaps, sort of depends again on the child and what the diagnosis is. So there are some children that I know will be wearing in long contact lenses, and I will want to do something that is not limbus-based, so it disrupts the limbus less than a fornix-based flap, or it's a child with aniridia. And with respect to the patch graft that covers it, I think that too is we've gone to using cornea, I would say most of the time. Most of the time we're using cornea. But even if I am using a corneal patch graft, I oftentimes will want to anchor my tube with a long scleral tunnel, and I have a video of that for you. This first video is just a typical fornix base Barveld shunt. I want to point out that I've noticed we all use different sutures for our corneal traction stitch. I tend to like a 5/0 vicryl because I think it cheese wires less through the cornea. Remember, these kids have very edematous corneas oftentimes by the time you're doing a shunt. You'll notice I don't loop any muscles. I don't know if you all do with 250s. That was a 250 Barvo. I tend to like my placement of my 8/0 nylon horizontally as opposed to vertically, partly because I think once it's secured in place, then it doesn't move. I know where it's going to be. Now that looked a little anterior if I had to criticize my own video, but it was about 8. I shoot for 8 to 10. And depending again on the age of the child, sort of planning on the eye growing. This is not a long tunnel. This is short. I tie off everything with usually a 7/0 vicryl, and I close my conj and tenons in one layer using a 7/0. I oftentimes will put an intracorneal mattress suture to hold it down, because when kids tend to rub their eye, they can dislodge a fornix base flap easily, and and then go on to have an exposed shunt. So I mentioned a long scleral tunnel. This is something that I learned from Jamie Brandt, who is at UC Davis in Sacramento. And it is really a handy little trick to have. And I have a short video of this as well. But I wanted to show you that this little angled mini crescent blade can be used to create a 2-part long tunnel, so that it anchors the tube very well. And honestly, in adults, after I've done this, I rarely use a patch graft. But in children, I almost always use it regardless of having this tunnel. This is putting the tube through the tunnel. And then I use a 23 gauge needle as usual to put it through the second half into the anterior chamber. These are the 2 initial incisions made just with the very tip of the mini crescent, dissecting to the first incision site. And you'll find too that your tubes really do not move as much. We've all been able to see our shunts move a lot at a slit lamp. These don't move once they're anchored in this long tunnel. This eye has a previous surgery above, and this is inferior nasal. Now I think inferior nasal this is a great technique because you really don't want that to move. I still tie these tubes off.
How do you tie them?
So I would tie this tube off with a 7/0 vicryl posterior to that initial incision. And I would, if it's a child, I cover it with a patch graft. There have been some places where the cost is an issue. These really don't need to be, but with kids I do in case of rubbing. The nice thing about inferior nasal placements of shunts is that they're somewhat guarded by with the inferior rim from rubbing, but never underestimate how a kid can get in there and really rub their eye, no matter where you put it. So you have to be cautious of that. So I also mentioned that the diagnosis affects what I do. You know, I still do angle surgery on Sturge-Weber children. We all know that initially this is an angle problem, and then later on there's elevated episcleral venous pressure. But I would say this case, you can see obviously all these dilated vessels, and this is one that when you know, looking at this, I would be seriously concerned about either intraoperative or postoperative choroidal detachments. And I think on every child or any even young adult who's having shunt surgery with Sturge-Weber or any vascular anomaly, to seriously consider how can you maintain the pressure so there aren't rapid changes in pressure. So Helon or viscoelastic, I do not recommend using something that's difficult to remove. I like regular Helon. I've gotten away from an anterior chamber maintenance device, but that is something that I know Sharon Friedman uses frequently for hers. I find that I sleep better if I don't fenestrate. Now you can do fenestrations, and if you choose. Another way around that is if you have a shunt that has a suture ripcord stent and then still tie it off is good. Stage procedure, I admit, is similar to what Elena described in the very first presentation. I would do angle surgery on this child and then place a stage 1 shunt. It is really quite reassuring. If you're doing a stage 2 and you know all the scar tissue, the resistance, the outflow is there, that when you put in the shunt, you're not going to get a rapid change in pressure. Now, do I tie those tubes off? It depends on how long ago the initial surgery was. If it's with less than 6 months, I do tie that off as well. Prophylactic sclerotomies, I've gotten away from doing those. It sort of depends on how the case goes and what I see. But if I do, I make a very simple cut down 3 millimeters posterior to the limbus using a Kelly's Decimase punch. So what about another diagnosis that tends to be unique when we're putting in shunts in kids, and that's aniridia. You know, aniridia is a very poorly named diagnosis, as you probably know. There are some children that have quite a bit of virus, but one thing that they certainly do is they have an abnormal cornea and an abnormal limbal area. And for that reason, and since corneal opacity and loss of limbal stem cells becomes such a great problem later on in life when they get to their teen years, I like to do anything I can to avoid touching that area. And so I do those as limbal-based incisions for my tube shunts. And obviously, I saw some questions come up in the question and answers that I was looking at when you all were speaking, the other speakers, about antimetabolites. I rarely, I'd say I can't remember when I've used an antimetabolite on a child. So, and in this case, I would say you would never want to. The scleral tunnel is a great option too in these shunts, just for the same reason, again, of trying to avoid doing too much to disturb at the limbus. The other portion that you wouldn't think of, and it looks scary to see that tube over a lens without any iris between your tube and the lens itself, you need to make these tubes a little bit longer. there is often in aniridia a nubbin of iris that is not normal, so it's very floppy, that can occlude a short tube, just to remember that. This is a limbus-based shunt. Again, the corneal traction, measuring posterior. You know, the part of where you want to incise is a little bit tricky, because you want to make sure that you're still away from the limbus. Now, in this particular patient, this was to wear contact lens. You also want the opening not to be so that you're closing this conjunctinons immediately over any plastic. Now, this video is unusual for me because I quite honestly don't usually put my barbells under the muscle. I place it on top of the muscle. But it really depends on the situation. And again, if it's going to be someone who's going to rub the eye, and I'm worried that it won't anchor before it has a chance to develop a fibrous band. And this video is courtesy of Jamie Brandt. And he routinely does a limbus-based, but again, I think it's important in aniridics, and also if you want to try to save the limbus for a nice smooth limbus that will be able, the child will be able to wear a contact lens. So for example, one that never had an IOL, you don't intend on putting one in. This is 8/0 nylon and tying the tube off. You know, testing to make sure your tubes are tied off is a subject all unto itself. I would say that having a tube not completely occluded is probably one of the most common novice mistakes that happen that lead to every complication you can imagine, from flat chambers, suprachoroidal hemorrhages. And so having that tube be nicely occluded is, I think, important. Anchoring tubes down in adults is not frequently done, at least here in Miami, but I certainly do in all my children, and this is the same technique with a figure of 8 over the top of the tube and some fenestrations. You'll find fenestrations work better if you do them at the point where the tube itself is beginning to go to bend as it enters into the plate. If you do it too close to the entry site, the tube is actually too much in the same plane, and your fenestrations will not work. This is a double layer closure, which is highly recommended if you do limbus-based in kids, because you're just less likely to have a through and through leak. Sorry about that. So what about the situation of uveitis, another problem that we see in kids that we commonly go to shunts? And shunts are sort of the knee-jerk response to uveitics, but I will tell you that there are some uveitic secondary glaucomas in children where angle surgery is quite reasonable to start with. And in fact, I think have less complications than do shunts. Because in shunts, you're more likely to wind up with hypotony that is prolonged. And you'll find that hypotony is something that is sort of a self-fulfilling prophecy, in the sense that once the pressure is low and the ciliary body becomes detached, in uveitis, it's very hard for them to ever catch up. So how do we avoid it with our choice of shunt in these kids? Once you've made the decision that you're moving on from angle surgery or not going to consider it, and you're going to go to a shunt. This is one of those rare times when I do consider valve devices. And so you know, that's a limited choice, and you can do that, but you can also choose one of the non-valve device and use a ripcord that doesn't completely occlude the tube, but that you can tie off and occlude it completely with a ligature combined with the intraluminal stent. And then the other option, and one of my preferred, is if it is a child that is having a pars plana vitrectomy, if you can engage your retina specialist, involve you when they take the child to surgery, you can place a stage 1 shunt. And that is probably the slickest way to do a tube in a child with uveitis, because then the shunt has a chance to really mature, the scarring around the plate occurs to give good resistance to outflow when you put the tube in, and you have the added benefit of being able to put that tube into the pars plana and be well away from the cornea and also the iris, which can cause more inflammation if your tube should touch it. This is a nice picture of a device, the ClearPath, this here, that comes with a intraluminal stent already. And the stent does not completely occlude this tube. So there is still some leakage around it. So if you tie off the tube, in addition to having this ripcord, you'll have no flow. But when that dissolves in around 6 to 8 weeks, you might have enough flow that you can still leave that stent. Obviously, in a child, you have nothing exposed. You would have to take the child back to the operating room to pull the ripcord. So what about the most common secondary glaucoma in kids, and that's glaucoma surgery following pediatric cataract surgery. And again, position of where you put the tube is so important. And if you can, anywhere away from the cornea is best. I think those corneas are not normal to begin with, plus they've already had cataract surgery. And I think if you're able to put the tube in the sulcus behind the iris, it is the preferred position. With that in mind, though, you have to worry about the risk of the tube occluding, and you need to make that tube long. Leaving the tube long also helps so that if you have a high pressure, you're not guessing, and you're able to see the tube and know whether it's been occluded. What are the complications from shunts? Those of us on the call who do lots of them, we've seen them all, and we never want to see them again, but they happen more often, and when it's more frustrating, and I think more of a challenge to manage in children. But hypotony is certainly something to consider. Again, early hypotony you can avoid by tying off your tube wells. The occlusion of the tube, keep your tubes long. Endothelial tube touch, this happens as the eye grows. And I don't know if you can picture in your mind that as the eye grows and the plate of the shunt moves posteriorly, it allows for the tube to come anteriorly and migrates literally towards the endothelium. Erosions you can avoid. I think in children they happen more because of eye rubbing. I like the scleral tunnel covered by a patch graft for that reason. The migration again is with the tube growth and the change of the tube length. If you've made your tube too short because you haven't taken into consideration the fact that children's eyes grow, then that's a problem. Now, strabismus I have mixed feelings about, because I mentioned to you a minute ago that normally I do not put these shunts under the muscle, but I still get strabismus. it can act as a large mass effect and cause displacement of the globe. But I personally feel, I have no data and I haven't published this, I personally feel though that the incidence is less.
Alana, can I ask you something?
Sure, Albert.
With endothelial cell touch, I've noticed that when, we've all, recently have tended to do these long scleral tunnels.
Yes.
But I found that when you do that, the tube is always angled more towards the endothelium.
It can be. I think the trick is on the entry to instead of, and I think maybe I should video that too. When you do that secondary, when you do the 23 gauge needle into the eye, to aim it, to come in more posteriorly and aim it down. We tend to try to aim up because we're afraid of being too deep. But I think if we aim down, but I will tell you, Albert, in kids, I still see it come forward. And then sometimes, and this is a little trick to, when you just get this tip hitting here and you don't want to reposition how the tube is entering, but you just need to change the length of it. It's a simple stab incision. You grasp it with your small forceps, trim it, and redeposit the tube and a single 10-0 nylon. But that's if you're lucky enough that you don't need to reposition the whole tube. Now, repositioning them with the scleral tunnel is a challenge. It really is, because the tube is very anchored posteriorly. And so repositioning it along the limbus, you're limited unless you have a nice long tube. So before you do the tube trimming that I just showed, make sure you don't want to reposition the entry completely into the eye, because if the tube is short and you need to do that, it's awfully hard. Again, it's a very simple procedure to do. So I want to thank everybody for listening, and if there are any questions, I'll entertain those now. Thank you.
Thank you very much. Wonderful presentation, Dr. Alana. That's really great. I'm afraid there are lots of questions, but we need to move on to the next talk. So we'll take Dr. Albert, and then we'll go back and discuss. There are lots of questions on tubes that we and the audience would like to ask. Dr. Albert, would you like to start screen sharing? So our final speaker today is the very talented, very pleasant Dr. Albert Khoury, who is an associate professor of ophthalmology. He has a very busy schedule directing the hospital's glaucoma service, the ophthalmology residency program, the telemedicine program, and the clinical trials laboratory. His main interests include developing new medical treatments for glaucoma, as well as novel surgical techniques, including MIGS. He's also interested in telemedicine and, of course, in childhood glaucoma. Dr. Albert, would you like to start?
Thank you so much, Yasmin. It's a pleasure to be here and see everyone virtually. This is the world we currently live in. So those are my disclosures, and none of them are directly relevant to the subject here of lasers for childhood glaucoma. And the panelists have went through the entire treatment paradigm, and this is a surgical disease, obviously. So, but those of us who treat children with glaucoma, you invariably fail with some of those patients. And when you get to that stage where, you've went through the algorithm and you've done your, your goniotomies, your ab interno approach, your ab externo approach, a tube shunt, but the pressure remains uncontrolled, we tend to use laser treatments. And I wanted to focus some of the discussion today on micropulse, because I know a lot of us are interested in this new development with diode laser delivery, although there's not much literature on this. So I did a literature review, and I've updated this presentation to cover most of it. But ciliary ablation is not new. You're all familiar with it. and invariably, it's not an end, it's an end stage treatment, but it's not a long-term treatment in that the success does go down over time with the ciliary ablation. And those are two series from Saudi Arabia and Australia that show that does see. This slide is just, I just wanted to series from Rutgers where we've looked at our outcomes with CPC, and the majority of eyes actually do need more than one treatment. We know is a dose energy response. On average, most eyes received about 100 joules of treatment, and I want that number often later on with micropulse. It's mostly from retrospective series, but again, this is a CPC, and most series have shown that single treatment. And the success rate is variable. It's about 50% or less with a single treatment. Improves to about in the 70% range with the repeated treatments. The challenge with is the complications that we run into. Often these eyes are very sick and they're towards the end in terms of their visual, but you could sympathetic came out this afternoon in one of the presentations, but you could get hypotony, phthisis, and lose those eyes if you are overly aggressive with them. And that's where micropulse CPC comes along. The company that makes the G probe discontinued the older machine with the older units, and the new unit does have the capacity to deliver micropulse, and the advantage that is talked about with micropulse CPC is the fact that the laser is not constantly on. You have a duty cycle, or an on and an off, and during the off cycle, there's thermal dissipation, damage to the tissues, and potentially less side effects. The technology is evolving as well, and I'll talk about our experience with this in first generation probe for the micropulse. Well, bulky, was hard to use. The new the generation, the last that was released, is a little more ergonomic. The tip is smaller, and I think their dissipation and loss of energy. This is a publication that the company that markets micropulse CPC, Iridex, basically often and it really looked at the energy delivered and the response to treatment, and shows like around between below 150 joules, where you have the more energy used between 50 and 100, but once you hit the 150 joule mark and more than that, you tend to get more complications. With the literature, there's very few literature on this. The review morning again, I just did not want to miss anything, and there's really not much published on dose response. And I think this is what triggered this editorial by Harry Quigley. It's in this month's Ophthalmology Glaucoma. And if you have access to it, it's a very good read. Harry highlights is the lack of evidence with a lot of these new technologies and new surgeries that are quickly adopted. But there's not much high-level evidence, like there's no randomized clinical trial or micropulse therapy, for example. And although the hypothesis is that it has an advantage over continuous wave, that has not been proven in studies. And looking at the literature with micropulse CPC, there's actually two papers, both from Egypt. One is prospective. They're obviously all smaller series because childhood glaucoma is not that prevalent. And the first one, it was 36 eyes, aged 16 and younger. So obviously not all PCG. It included a mix of glaucomas. And they were treated conservatively, 3 quadrants at 40 seconds. The duty cycle on the micropulse is fixed. With a good response, the pressure reduction was about 37% at 15 months, and the medications were lower. So overall, a favorable response. This is the Kaplan-Meier from that study that shows a pretty decent response to treatment. But again, the duration of the study is short, so the mean survival was around 9 months. And of the additional interventions. Another paper also from Egypt on micropulse versus continuous wave, slightly larger study, 45 eyes. It included 2 arms, continuous. Success was liberally, as you know, as is the case with a lot of glaucoma. So a pressure below 21, a 20% reduction, or a reduction in follow was short at 6 months. This is both treatments work. How micropulse arm had more patients that were previously treated continuous wave CPC, so they were kind of, the success is pretty impressive at 63. But they looked at complications in this study, and hypotony can occur with micropulse, even with conservative treatment like was done in this case, but less so than with. And from my own experience, I've had a child that was hypotenuse for a period of time after. The Kaplan-Meier, again, this is a short-term study that showed that micropulse worked a little better than continuous wave, but as I mentioned, a lot of those eyes had, this was a second treatment, and that pulse carried a lower rate of complication than continuous wave, although the numbers were. Another study, this is the only one that I also found that compared to continuous wave and micropulse, a very small series, not published from CSF, but some of the patients were also from China. And the response to this treatment was pretty disappointing. It did not work for the majority of eyes, although they used a lot of energy. They did 160-second sweeps per hemisphere, which delivered around 200 joules, yet the response was less than the authors expected. But again, this is a small series. And when I looked at the type of glaucomas in this series, basically a single patient had, all the others were more refractory secondary glaucomas, and this refractory. Just to close, I mean, initial experience at Rutgers with micropulse and continuous wave, it's ongoing. But when I was too conservative, those are babies, and I did go just by what the company recommended. So I quadrants, sparing a quadrant. But I quickly realized that that was very little, and that a lot of those eyes required retreatment. So I went on to 4 quadrants at the original settings with the first generation probe. and the results were a little better. But most recently, over the past, I would say 6 months, we have the new probe. So, I mean, the technology is constantly evolving, and it's hard to compare your results when you're changing so many variables. One hard lesson I learned, and for those of you that use micropulse, at one point we were using lidocaine jelly, which is transparent, and then that was on back order. So I used Tobradex ointment for a bunch of these cases, just as a coupling solution on the surface of the eye. But the tobramycin, actually, there are crystals in the solution. It's not completely transparent, and basically those eyes required a retreatment, and I think that is due to a lot of the laser energy scattering and not being delivered to the ciliary body. So going back to this, we definitely know there is an energy dose response, and we do not know as of this time what is the optimal energy to get a decent pressure reduction, 20 to 30% reduction. And I think this has to be worked out. This goes going back to Harry Quigley's editorial. Each of us is trying to determine this on our own, but I think a multi-center collaborative effort would allow us to answer this question in a better way. It seems like around 100 joules is where we want to be, but I'm not sure that that works for all eyes. So I think has a role. It seems safer than continuous wave, but young eyes heal very well, and often these treatments do need to be repeated, and that's a discussion I have with the parents before doing CPCs. I do use subconjunctival steroids because I've been stung a couple times when the parents did not use steroids as I wanted, as get inflammation if the eye is not needed. So I think it's safer in children to give some subconjunctival depot. You definitely need to use a clear ointment for coupling, nothing that is like Tobradex. And as I mentioned, the technology is evolving with the new design of the probe. I think it's easier to use, it's more ergonomic, it's smaller. So it definitely has advantages, but there's so many variables that we still have to work through response. So incisional surgery remains the main treatment, but lasers are the go-to when all else fails. And I think we will be learning more about micropulse coming a few years. Thank you.
Dr. Albert, that was brilliant. So we have some time for questions. So can I start by asking you, do you ever consider doing a micropulse as a primary procedure in kids? Especially, there's a question from the audience. If you don't get to follow your patient for a long time, like patients who come from abroad for a single treatment, would you consider a micropulse for those or any other cases as a primary procedure?
That's a good question. And for patients that are leaving town, I mean, you try to avoid incisional surgery. I have limited experience with a single patient that the cornea was very cloudy. Not staying. I knew this was a PCG on presentation. I ended up doing a micropulse. 3 quadrants. This was in the early days. And actually the patients, the fat town came back. Was clear.
Sorry,
the pressure was still in the high 20s. So I broke out.
Yeah.
So I started with a micropulse. It did work. The cornea cleared up. And then I did a goniotomy afterwards, actually, when they returned to town.
Brilliant.
Yeah.
Okay, so since we didn't have time to ask you, Dr. G, after your presentation, we just wanted to ask you a couple questions. So I noticed in one of the videos you put the plate over the muscles. Why do you think this would make a difference?
You know, I routinely put my barbells, whether they're 250 and 350, over the muscle. It has to be a special situation that I go to the trouble to hook the muscles and put it underneath. And I do this because I think that the increased surface area allows for lower pressure over time. And I also have not seen the downside of the plate moving, especially if it's allowed to heal, you know. So you have to have it so the child's not rubbing their eye early on. Because of those holes in the plate, in the barbell plate, it grows fibrous tissue and anchors it very well. But my real reason is I think you get better pressure lowering with the increased surface area.
And, you know, talking of surface area, do you think there is any difference between the 250 and 350 in efficacy?
Well, you know, if you're above the muscle, 350 is significantly more effective in getting a lower pressure. But I honestly have had good results with 250s, not putting one side under the muscle, which people routinely hook the muscles, even though both sides don't fit under the muscle, one side does. But I think there was a question from the audience that had to do with, does the pressure affect your choice? And yes, if I think they have high pressures and I want a very low pressure, I'll put a 350 above the muscle. If it's just average and it's a primary congenital glaucoma and the orbit is small, the face is small, I'll use a 250.
Interesting. Albert, I wanted to ask you about your continuous wave settings. So what were these, like pop settings? Like you go up, like, you know, until you hear a pop and go down, or what is the
with micropulse you're asking?
No, for the continuous wave, like, because you're you know, in the Rutgers series, you're comparing between micropulse and continuous wave.
Correct.
So for continuous waves, what settings are you using?
With continuous wave, again, the numbers on the slide were mean numbers. So, and because this was over a long period of time, the parameters changed. So initially we were doing like 2,500 milliseconds. 0.5
milliwatts. Oh, 2,500 milliseconds. Okay.
Seconds, and we always titrate to a pop. I mean, if there is a pop, I go down.
Okay. Dr.
I'll have a, oh, sorry. Yeah, okay, go ahead.
Yeah, I just wanted to ask Dr. Hala, so where does laser cyclophotocoagulation fit into your congenital glaucoma treatment paradigm? And you're muted, so if you just click unmute.
The cyclodestructive laser, like that. I do like when I done other procedures, usually when I already have 350 barbells in the eye, so I can treat what I can of the other quadrants of the eye with laser, with CPC. I like the micropulse better, but I do it as a last resource. And I've been getting, with the G probe, I was very, very conservative. With this, I still got a little easier, but I have the conversation that Dr. Khoury has said with the parents. It's like, it's likely that we need something else. I have 2 tusions, I done angle surgery, I have 2 tusions in the eye. I'm gonna try this. It's not, I don't deliver as high of an energy, but I might have to do a little bit more. Yeah.
What about you, Dr. Hala?
So again, yes, I do exactly like Dr. Khoury said. And this is the usual treatment, and I keep that till the very, it's my last choice.
Dr. Hala, I'd like to ask you, what is your primary procedure for aniridic patients? Because you see a lot of those because they come in with the cataracts and sometimes with the glaucoma. So what kind of primary procedure do you prefer?
If I can get a view of the angle, because sometimes they have corneal opacities, and if I find that the angle anomaly is consistent with the trabecular dysgenesis, and I don't have the stump of the iris closing up the angle, then I would go ahead and do a goniotomy first for them.
Zainab, do you have any experience doing GAT in anaridic patients? Have you ever had a chance to do GAT in anaridic patients?
No, no gap, but of course I did goniotomy, but no experience.
Not yet.
Okay. Not yet.
Okay, I have two questions to Dr. Alana about tubes. So, Dr. Alana, when would you consider primary tubes in pediatric eyes? And the second question is, do you ever stent the tube as a routine procedure in the regular cases where you wouldn't, not just the Sturge-Weber, but in other cases?
So I personally really try to avoid a shunt as the primary procedure, but if the anterior segment is very disrupted, and also we have patients that are leaving the area, and I might only have one chance at that child, those children I will put in a shunt as the very first procedure, because it may be the last time I see the child. But if I can, I will do something else. I really love what Albert said about doing the laser and clearing the cornea. I mean, if that would be such a brilliant idea if that works on some kind of, regular basis, Albert, because, I love all of our ab internal procedures. And, we were just talking a minute ago also about aniridia. Aniridia is the perfect case to try to do things inside rather than disturb the limbal stem cells. And that would be so great if we could clear the cornea enough to see the angle and do a GAT. And I think if you're brave enough to do a goniotomy in an aniridic, you may as well do a GAT. I mean, the scary part is coming across the angle, and you got that lens there, and so, but
it's no big deal.
Nerves of steel, nerves of steel.
Can I ask a question to Alana, Yasmin?
Yeah, sure. Yeah, go ahead, please.
Yeah, the only tube option in Turkey is Ahmet valve. So I have a question about Sturge-Weber syndrome. In a case, an older kids with Sturge-Weber syndrome and diffuse choroidal hemangioma. In those cases, I tie the tube off. So in an Ahmet, even Ahmet. So what would you do? Would you consider tying it? Because the choroidals might occur at high IOPs in those cases. So yeah, I found my way doing this. So but I'm not sure what's happening to valve mechanism when I tie this off.
I have wondered the same thing, and I've tied them off also. But you know how you prime your valve with balanced salt? I've actually primed it with Helon. To try to keep it from sticking back together. And I don't know if I'm right, but in my mind, it's like two pieces of cellophane that get stuck together. And so if I could keep it apart so that when I tie off the tube, and then when the tube opens, these aren't stuck together. However, let's just say, and I don't know, maybe the other panelists have experience with this. Let's just say, because I think many of us tie off the tube in an Ahmed. On occasion, I've had it where the dang thing doesn't work. When you don't get any bleb over the plate, that the ligature is gone. That's when you can do that simple technique of just the stab incision, pull it out, externalize the tube, and then irrigate it to expand it, put it back in, and it will work. But it's frustrating. But try priming it when you do that. Prime it with Helon into the area that's in the where the valve is and over the plate. I don't know if I've broken the valve. I hope not. But
so do you prime it?
Thank you.
So do you prime it, Dr. Rajewski? Do you prime it with Helon right away, or first with BSS and then you do the Helon?
BSS first.
Okay, nice.
Elena, there was a question that came to you after your talk. It was on my mind to ask you. But I also would want to ask every single one of our panelists about the same thing. What is your exam under anesthesia schedule for follow-up after surgery?
So depends what surgery, depends also how the child, how he cooperates in clinic. Now, because of the new, with eye care for measuring pressure, I think we can afford to do less exams under anesthesia. But there are children that there is no way to do. So obviously we see everyone the day after surgery in clinic. A lot of times you cannot get a pressure, sometimes you can, sometimes you cannot, and you just, the maximum you do is just digital pressure and see that the anterior chamber is formed. Then we like to follow them a week after in clinic. There are children that I know we won't get absolutely any exams, and then we just get like a couple of weeks later, 2 to 3 weeks later, an exam under anesthesia. But it depends a lot on the severity, the procedure we've done, and the cooperation of the child. Some other children, if we can check pressures and they let us examine and we play with them, the clinic, it's made for kids. So that's an advantage. So we can, I think we have decreased the need for exams under anesthesia like tremendously. And then what we do is still, we need to measure axial lengths. We need to measure corneal diameters on kids less than 3 years old. So we still need to go to the operating room, but probably a little less often. Maybe we'll do in a few months. If in clinic we can check regularly, maybe like 2 months later, we'll take him to the operating room to check that axial length and make sure we are not missing anything.
Albert?
To that point, I think, it's very variable what we do. There's no hard science behind it, but I've been approached multiple times. Can you hear me?
Yeah, we can hear you better, actually.
It's better, yeah.
Yeah, because this just died, my earphones. I've been approached multiple times with parents that come in with literature on the effects of multiple sedation and general anesthesia on developmental growth of the child. So if we're dealing with a PCG patient that is like a month old or 4 weeks or 6 weeks old, I try to space apart the EUAs as much as I can, as long as I think it's safe to do so. When they're older, there's less effect, but that's a tricky area in childhood glaucomas that we don't understand very well, and there's not much literature on it. Maybe Alana can chime in.
I can chime in, but I don't know if I'm right. And I will say that I think that I don't see him that much. So I do the same as Elena. I see him first day post-op. I might see him 1 week if I can, but then I tell the parents to go away for a month or 2 months. If the eye is not infected, they have an anterior chamber, I look at the kid and it looks like eyes, I'm happy. I don't even need a pressure. I don't really care because it's not going to change my management that much. And I have found parents are better observers than I am. And I'll get a message on the phone and with a picture, I think the right eye is starting to look cloudy again. Oh, okay, let's start a drop. I have found that by engaging the parents as a part of the team, I have less exams that I go back. But Elena is right too, that before the age of 3, our hardest objective data has to do with axial length, and I'm sure the other panelists feel the same way. I love following that to know if a child is under control or not. That helps me a good deal, and that you only get under anesthesia. As far as the question about the PANDA studies and the general anesthesia studies, really, if you pull some of those articles, it has time that it says repeat anesthesias for longer than 3 hours. And these were looked at not just with eye surgeries, but with cardiac surgeries on kids. So there could have been confounding variables. But in general, if the surgery is less than 3 hours, the data does not support delayed development in children with repeat anesthetics?
It's just that, our EUAs take a long time, to be honest. So, between the measuring the pressure and the, corneal diameter, the B scan, the A scan axial length, the photos, an hour and a half, and then
retinoscopy.
And when do you take the IOP reading? At what point do you take your pressure reading to avoid it dropping?
I don't know about others, but I mean, for me, the most important thing is I don't get in the way of my pediatric anesthesiologist. We all know that there is the artificial lowering of intraocular pressure with the degree of time that a child has an inhalational anesthetic agent. There is not an inhalational anesthetic agent that doesn't lower pressure artificially. But from my perspective, what I do is as soon as I say, can I measure the pressure now, while they're under light anesthesia, I consider light anesthesia anything that is before intubation or the LMA is placed. And then I measure it afterwards. If you have a unilateral glaucoma, I don't break my back because the other eye is your control. So, but in bilateral cases, I do one under light and one under deep. And that's what I record. So that's basically where I am. So in the UK, they use a lot of ketamine because that is the one agent that doesn't lower pressure artificially.
It raises it, actually.
Yeah.
So actually,
I wanted to ask you. So when I worked in Saudi Arabia, they used a lot of exam under sedation rather than exam under anesthesia with chloral hydrate.
Yeah, actually, I do that. I use chloral hydrate more than I use general anesthesia. But I give it. I examine the kids in the recovery room still, in the in the theater, and I also find that I'm more comfortable with the pressure measurements because I know that I don't have the same pressure lowering effect that I'm getting with the general anesthesia. And I do the complete exam with the corneal diameter and the refraction and everything in that setting most of the time.
Some places, UCLA being one of them, have it set up so they can do that. Here, the insurance is charged the same if you do it in the holding area, and you may as well go to sleep. And here they got away from doing it in the clinic, which is, by the way, I agree with you. That's how we used to do it at Wills. But here they lost the airway on a child under chloral hydrate and in a baby. And it was, after that, it was, we're not going to do this in a setting where you don't have easy access to the anesthesiologist, which is what you're doing. You're doing it up.
Zainab, what do you do in Turkey?
So we don't see the patients under chloral hydrates usually. So our checkups are usually like Elena. I see the patient 1 week after the surgery in a clinic, and then a month after, and then 3 months after under general anesthesia. So that's what I do. And then after this, if the pressures are under control, and it depends on the clinical situation and the patient, and it goes on like that. And then I try to decrease the frequency of EUAs.
What a wonderful discussion. This can go on forever, I guess.
Yeah, exactly.
I'd like to thank each and every speaker from our distinguished panel, Dr. Zainab Aktas from Turkey, Dr. Albert Khoury from New Jersey, Elena Bitrian and Lana Brzezinski from Miami, Dr. Hala Hilali from Cairo. It was an amazing presentation. Thank you. Amazing meeting. Thank you so much all. Yasmin, thank you so much.
Thank you so much. much, Mohammed, and I'd like to thank you all again. It's the discussion and the talks have been amazing, and the questions are never ending. I think we're going to have to do a part 2 for this. Yeah, so thank you for taking part. I'd also like to sincerely thank Eva Pharma for their tremendous help in creating this event. Their support has been outstanding, really. And finally, to close, one last word of wisdom in these difficult COVID times, and that is, do not eat. You'll regret it later on when this is all over. Instead, you can read, pray, work out, and stay tuned to our next event. So a lot of events are coming up this month to keep you entertained. Our next event will be the joint meeting with the World Society of Pediatric Ophthalmology and Strabismus on the 21st of June. So we hope to see you then. Thank you, everyone, and stay safe.
Thank
Thank
you.
you.
Thank you.
Thank you.
Bye.
Bye.
Bye, guys.
Bye.
Bye.
Bye. Good night.